Okay, is it working? You can see as how it should be. Good. Okay, so thank you very much for this invitation, Xavier. It's been I've been very happy to do this because Xavier and I have had this discussion, this kind of debate before in other contexts here in Oxford, and I'm very happy to have the same thing, to present the same arguments at a Christian Bioethicists conference, because I presume in a way this is more challenging, but therefore more interesting for me. So I'm gonna talk a bit about conscientious objection in healthcare, trying to argue, to present some reasons why I think it's not permissible, morally permissible, professionally permissible. I will say something about that. But just to get into the topic, so to the great presentation, the great talk yesterday by Jason Herber. So many of the things that I will say, no, not many, some of the things that I will say, you might have heard yesterday, but I think it's necessary to frame the problem. So one thing I want to point attention to is that when we talk about conscientious objection in healthcare, that is, healthcare professionals who refuse to perform certain procedures because of their own personal moral beliefs, the discussion is often centered on such a thing like a principle of freedom of conscience, the value of conscience, for example, the value of moral integrity. And I think this is important. And there was some discussion yesterday about what conscience is. But I also want to shift a bit the attention on the other term of this expression, conscientious objection. So on the term objection, because it's important to focus on this fact. So when we talk about conscientious objection, we are talking about a claim that's more or less legitimate, that we can talk about it, that some professionals have to deviate from a line of conduct that would otherwise be expected of them. And I'm going to say something about the nature of this expectation. But when we talk about a conscientious objection, it's about a deviation from a certain standard. So this seems to me to suggest that if there is such a thing as a burden of proof on this debate, it will be on those who want to claim a right to conscientious objection. They might have a good argument, but the burden seems to be in the first place on those who claim it is right, because there is an expectation and there is an objection. It's mostly understood in terms of refusal. So most notably, the most obvious case is the case of doctors who refuse to perform abortions. But the issue of conscience comes up also in the case of conscientious provision. So doctors who claim, some of them claim a right to perform procedures that would otherwise be prohibited. So where the expectation is that they do not provide it. And I see Abraham Bromet is among the audience, so I know he wrote a lot about that. And I also responded to one of your paper. That was a very nice paper. So yeah, I'm not sure I will have time to touch on this point, but this is just to give a framing of this debate. So the question that I want to use to address this problem is whether conscientious objection, which here will be mostly understood as conscientious refusal, violate professional obligations. So not just permissibly infringes upon an obligation, but is a violation of professional obligations and therefore impermissible within a professional context. I'm not talking about general moral stances about abortion. I'm talking about the professional context and whether there is a violation of some obligation, professional obligation. Now, the question requires us to think a bit about what a professional obligation is, and therefore what defines professionalism. So what is a professional? Now, when I talk about professional in this context, normally we have in mind quite a specific and technical understanding of the notion of professional and professionalism. So there is a looser sense in which everyone who is paid to do something is a professional, but this is not the sense in which the term is used for certain kinds of profession. So, and healthcare professions is one such example. So normally, when we think of professionalism and professionals in a stricter, more technical term, we have in mind something like this. So this is a not exhaustive list of the condition that makes someone a professional. This is not about the healthcare context specifically. This is about what it means to be a professional in a technical sense. and is applicable to many other contexts. So the idea here is that, so this is the understanding that I adopt. So a professional is someone that, first of all, relies on some specialized knowledge and skills that requires some study and some training. So is something that requires time to acquire. So professional status is not something that can easily be achieved. So study and training is one aspect. But the second, and to me most important aspect, is that professionals in this sense are a group that have a monopoly over the provision of a certain service, over a certain occupation. And you can see that in the healthcare context. So healthcare providers, healthcare professionals have a monopoly over the provision of certain healthcare services, whereby I'm not allowed to provide certain services or perform certain procedures, but healthcare professionals are. There is this kind of peer assessment normally among professionals. So whether a professional has acted rightly or wrongly normally is assessed by their peers. And because there is a monopoly, so because society licenses professionals with a monopoly over the provision of certain services, normally professionals are expected to provide services or products that are valuable to the society. So there is this idea that society grants me some monopoly, some right over certain things, but that's because society expects me to provide something that is considered valuable. And that, again, seems true for not just for the healthcare professional, but for many other professions. And also, professionals normally, their conduct is regulated by ethical standards. Now, where the standards come from, how to formulate the standards, that's a big question, and I will say something about that. But normally, the idea is that the standard is related to the society serving ideal of the profession. So the fact that professionals are expected to provide certain services to society somehow determines what kind of ethical frameworks they're supposed to follow. Now, within this understanding of professionalism, we can zoom in into the healthcare professional more specifically. So if we think about healthcare professionals as professionals in the strict sense, so the question is, what kind of professional obligations derive from this notion of professionalism? So it seems plausible to me, and I think everyone will agree on that, that healthcare professionals have a professional obligation to provide, well, appropriate healthcare. Now, I think we all agree on that. What we might disagree on is what counts as appropriate healthcare. So this largely depends on what the aim, the goal is. So that is what health is. Now, health is a concept that is very problematic. There are many, many understandings of what counts as health. I will not go into that. But for the purpose of this discussion, so what is useful is to divide the camp into what I take to be the two main understandings of health and therefore of healthcare that are normally appeal to in the debate about conscientious objection. So I've called these two objectivist and subjectivist, but I've made this up. So these terms are, I came up with this. People will use different terms for distinguishing these two umbrella terms. But let's say that broadly, there are two main understandings of health that are relevant to the debate on conscientious objection. One is what I call the objectivist one, whereby health is understood mostly as the absence of diseases, so as the well working on an organism. So, for example, in terms of normal functioning, like statistically, this is Christopher Bohr's famous definition, or in teleological terms, this is more like Aristotelian view of health. So the idea is that every part of the body has a function, and someone is healthy when all the body parts fulfill their functions. And this is objective in a sense, because it can, in principle, at least be measured. So it's there. And then there are people who have a more, what I would call here, perhaps imprecisely, a subjective view. So, and this is the view whereby health has more to do with the well-being or the interest of people. Now, I used here the WHO definition as an example, not because I like this definition. I think this definition is implausible, but it's one example, widely used example of this kind of understanding of health in terms of well-being. So these are based on the subjective experience. But within this camp, we can find also accounts of health and for healthcare that are based on autonomy. So whatever patients or people want to or think is good for them, automatically might be good for them. So there are many ways of conceptualizing this notion, but roughly these are the two main camps. So these are umbrella terms. There are many understandings of health within these two camps. So one problem here is that one reason why people disagree about what counts as health and as healthcare is that health is ultimately a normative concept. It's not a descriptive concept. What we consider to be health and healthcare is a decision we make about, for example, what kind of state of an individual is valuable and worth pursuing, in this case, specifically through medical means or through healthcare expertise. But these are based on values. So whether health is a matter of well-being, or whether health is a matter of certain function of the body doing their job in certain ways, is a value choice. So the question is, how do we make this decision, given that we disagree about what counts as health? And given that this is really at the root of a lot of disagreement around conscientious objection. Now, I don't know how we make this decision. There are many problems here. One is that I said that health is something we decide what is valuable, worth pursuing through medical means. One question is, who is we? So who makes the decision about what counts as healthy? Now, while I don't know, I don't have the answer about who decides what counts as health and healthcare in any specific context, I think I have an answer about who should not decide about what counts as health. And that will be, in my view, individual healthcare professionals while dealing with their patients based on their own conscience. So I do not think that my own conscience or your own conscience as a specific healthcare professional is what should be used to determine what counts and doesn't count as healthcare. And the reason for that is that because healthcare professionals are professionals in the specific technical sense that I said before, and because they have a monopoly right over the provision of the services based on some societal license, one requirement for healthcare professionals is that they need to be accountable to the society that grants them their monopoly. And this is evident by the fact that, for example, healthcare professionals are required normally to take oaths when they start their profession. So oaths, public oaths, are declarations that somehow signal the kind of commitment and accountability that doctors take towards the society and the people that they will serve. So the idea that oaths are part of the profession and the idea that oaths are really related to this notion of accountability is well expressed including by many people, including people who tend to be in favor of a right to conscientious objection. But the idea is that what these people will disagree with me about is about what counts as a professional conscience. But the idea that oaths express some kind of accountability towards society is quite a widespread view. So I have a quote here. I will not read the quote from Thomas Cavanaugh, and is one example of the many views that support the idea that oaths are really about accountability. So declaring something to the society that gives you the right to operate in a certain context. Now, what Cavanaugh says here is that healthcare professionals, when they start a profession, they declare what it is that characterizes their profession and therefore the kind of goal that they will pursue. Now, the question is, what is it that characterizes the healthcare profession? Now, if I'm right, and I think I am, and you will think I'm not, but if I'm right that it cannot be individuals' own conscience that determines what professional obligations are, and therefore what the goal of medicine and healthcare are, what alternative do we have to decide what counts as a professional obligation? Now, in this article that we published recently with my co-authors, we identify what we take to be three plausible models of professionalism and therefore of professional obligation, what we call the legal model, the professional organization model, and the ethical standard model. According to the legal model, professional obligations are simply determined by the law. So because society grants the monopoly rights over healthcare professionals, with the expectation that healthcare professionals provide certain services, one might say, well, whatever society deems legal, whatever the society considers legally available in a certain context through healthcare means, that is what healthcare providers should provide as a matter of professional obligation. This means that in places where, for example, abortion is legal, and within the legal limits, healthcare professionals should provide abortion services. This also means that in places where abortion is not legal, then healthcare providers should not provide abortion services. So, and this is related to the issue about conscientious provision. So will be an obligation not to provide abortion. That's because the law determines the rules of professionalism. According to a second model, some other people have this other view. The idea is that professional obligations are determined by professional bodies, professional organizations. So whatever a certain professional organization in a certain context decides to be, that is good medical practice or appropriate healthcare, that is what healthcare providers should provide. For example, in the US, the American Medical Association considers abortion consistent with good medical practice. If this is consistent with good medical practice, that's the standard of professionalism that healthcare professionals ought to follow, and they should provide abortion. Now, you can easily see how these two models can conflict with one another. Not just with one another, also internally, because one requirement that basically all professional codes of practice include is the requirement to operate within the law. And that's made a matter of professionalism. So this creates some tension, not just between the professional model and the legal model. Say, if abortion is illegal in a certain context, but in the same context, the American Medical Association considers it consistent with good medical practice, there is a tension. But there is also tension within the code of practice itself. If something is considered consistent with good medical practice, like abortion, but at the same time, doctors are supposed to follow the law. So there is some tension here. The third model is what we call the ethical standard model. And basically the idea here is that professional obligations are determined by the standards of good medical ethics or good clinical ethics, whatever is consistent with good medical ethics. Of course, big question is, what's that? Who decides? The traditional view is that there are the 4 principles of biomedical ethics and determine the permissibility, but this is very easy to say. In practice, there are a lot of conflicts. Not everyone agrees with this kind of principalism. So there are many problems with each of these models, both internally and also in terms of consistency. In an ideal world, and indeed in many cases, these 3 models overlap for all sorts of things, but the problem we have is with the odd cases where they don't overlap. And so there is this tension. And these are the cases where conscientious objection usually arises, so abortion most obviously. So these models can come apart. They're not without problems themselves. However, the problem I have here is with the solution that many people find. And the solution is that when there is some conflict, uncertainty, disagreement, then what should prevail is what I call the conscious model. So professionals should be allowed to follow their own conscience. And I don't see that as the solution to the problems that the other 3 models have. And this is for a number of reasons. I will not have the time to go through all the reasons here, but one reason for this is that there is an obvious distinction between professional and private life. So professionalism, the notion of professionalism exists because there are certain rules of conduct that professionals are supposed to follow as professionals and not as private citizens. And this is one reason, for example, why I'm not really convinced by the arguments that are based on so-called reasonability views. This was briefly discussed yesterday as well. So the idea that we should respect some kind of reasonable pluralism within the healthcare profession in the same way as we have some kind of reasonable pluralism in society at large. So if abortion is a reasonable view within this idea of reasonable pluralism, then abortion should be one of the things that doctors should be allowed to object to. I have problems with transferring this requirement about reasonable pluralism from the societal context to a context that is regulated by its own internal norms. So this is why I'm not very convinced by that. And the other point is that I'm not really convinced by the idea that many people put forward, that the idea that medicine and the healthcare profession is a moral enterprise. I've quoted the Mark Wickler here, but this is quite widespread. Many people use that. And therefore, there is some kind of professional discretion that requires the exercise of professional's conscience because to pursue these moral goals of the healthcare profession. So I'm not sure what it means to say that the healthcare profession is a kind of moral enterprise, no more than any other profession that pursues some goods. The legal profession is also a moral enterprise, maybe, but the legal profession has its own internal norms that professionals have to follow. So I'm not sure what that means, what makes healthcare different in that respect, but also assuming it is a moral enterprise, all that means is that there are certain moral norms, moral rules that professionals have to follow. And I agree that there are. My problem is about who dictates those moral norms, moral rules. My problem is with individual conscience, being the arbiter of these moral rules, when you can have moral rules and moral standards that are set, for example, in codes of practice or in legislation. So an ethical standard does not necessarily mean a standard of my own conscience. It means a standard based on certain values. And then we can have a discussion, which needs to be a democratic, a political discussion about which values should regulate the healthcare profession. I'm not convinced by the point that it should be your own individual conscience to determine these values. And that's because there is a professional conscience as well as a personal conscience. And these two things can come apart. So being a good professional, to me, I mean, that's the argument I'm trying to make, means to follow the requirements of professionalism, not so much the requirements of your own conscience. So a conscientious professional, one might say a conscientious professional is someone that in certain circumstances can set aside their own personal moral views to follow the norms of the profession. That to me is a plausible understanding of what it means to have a professional conscience. How are we doing with time? I think, have I used all my 25 minutes?
No, I think you've got another 5 minutes at least.
Okay,
and feel free if you want to take a little bit more time.
Yeah, I mean, this presentation is much longer than the time, but I can stop at different, so I can move on with this. Now, so some people would disagree with me because they would say that, in fact, doctor's conscience is important because it's important that doctors can exercise some discretion. And you cannot exercise that kind of discretion, but including about ethical issues that come up in clinical encounters without having a conscience and following your conscience. And Xavier has this very nice article in the Journal of Medicine Philosophy where he makes, among other things, he makes this point, and he gives this example to support this idea of abortion that is performed for sex selection purposes. So what Xavier says is that gynecologists, for example, would be unable to exercise their discretion. Now, sorry, I can't read the whole slide because I have the window. Anyway, when performing abortion for sex reason. And the idea here is that practitioners need to exercise their own conscience in order to come up with a view that abortion for sex selection reason is impermissible. But I don't see why conscience is what should be relied upon here to come to this conclusion, because we might agree that abortion for sex selection is impermissible. If it is not because my conscience or your conscience tells you so. It's because there must be some kind of ethical framework that tells me as a professional that sex selection, abortion for sex selection is impermissible. So if we have an ethical framework that rules out sex selection, abortion for sex selection, that's all I need to say that abortion is unethical within the profession, so is unprofessional. I'm not convinced by the fact that your own conscience is necessary to come up with this kind of ethical judgments. And also, your own conscience, I mean, my own conscience is at least as likely to be wrong as ethical codes of practice are. So some people say that one argument is that legal professional standards might well be wrong. So it's important that healthcare professionals can keep some space for their own conscience to identify when things go wrong according to the rules of the profession. But then even this argument to me is not very convincing because I can raise the same point. What if a doctor's conscience is wrong? So it's not clear to me that leaving decisions up to doctors' own conscience reduces the risk of misconduct. In fact, the advantage of relying on professional standards is precisely that there are democratic means like that societies have in order to question, change, challenge, modify this kind of standards. And there can be an open discussion about what the standards of profession should be. For example, I'm very, very happy to have a discussion about whether or not abortion should be part of the proper scope of healthcare. Some people think it shouldn't. Some people think it should. We should have a discussion, but ultimately, my problem is with saying your own conscience as a doctor, as an individual doctor, is what should determine whether abortion is or is not part of the profession. The fact that we can have an open discussion, to me, is what reduces the risk of misconduct, of including things that are impermissible or excluding things that are permissible. Now, things can go wrong, no doubt, with ethical code of practice. And that's where your own conscience may be what alerts you that things are going wrong. But in that case, there are other ways in which you can, at least democratic society makes other means available to you in order to change this norm. So you can campaign, you can have an open discussion, you can have You can have your political party that supports certain views, and that opens to open democratic discussion. In extreme cases, civil disobedience is an option. But civil disobedience will be an act contrary to the law that is aimed at bringing about a change in this legislation. Sometimes people do that, but people pay a cost for civil disobedience, jail time sometimes. That's how abortion was legalized in Canada, for example. You might be familiar with the story of Dr. Muggenthaler, who started performing abortions where abortion was illegal. He was prosecuted, ended up in jail. Then other people started doing that until there was enough pressure to change the legislation. So then maybe the same on the opposite side. If you think abortion is not permissible, your conscience tells you so, you might be right, it might be the right view, but this would be a way of bringing about the change, because that suggests that you're actually concerned about the standard of the profession itself, with avoiding misconduct for the profession. The problem is that conscientious objection doesn't do that. Conscientious objection is just a claim to keep one's own hands clean, so to speak, but first of all, without paying any legal consequence, but secondly, without necessarily having a claim about any change in the ethical framework of the profession or in the legislation. So in fact, we have conscience clauses whereby the legislation or the framework of the profession stays the same. It's just that people claim a right to be exempted from certain service, from performing certain services. To me, that's a bit of that's not the best way of pursuing a certain view of medicine, because it's not a way that is going to change anything. You just protect your own conscience. You don't bring about any change in the profession. So that's one other reason why I'm skeptical about a possible right to conscientious objection. Yeah, so I think I used my 5 minutes that I had left. So I had other things to say, but maybe they will.
If you wanted to take a few minutes, you're most welcome to.
No, I think it's fine. Yeah. So because this thing will require more than a few minutes, so I think sure. I'm happy to stop here. Thank you very much for your attention. So this, yeah, thanks. Should I stop sharing? Is that correct?
That'd be, yeah. Thanks very much.
Mute myself.
Okay. So can everyone see that okay? The screen's going through, great. Okay. And just let me know if at any point my audio is a bit weak. And same thing with, hopefully my Wi-Fi holds up here. So can I just say, by way of introduction, that I am tremendously grateful to Alberto for agreeing at very late notice to participate in this debate. And he's been very amenable to participating at late notice, which I am very, very thankful for. So thanks so much, Alberto, and for a thoughtful presentation. So I am going to present a different perspective on this question of the if you will, this broad topic of the ethics of conscientious objection in healthcare. And I thought Alberto did a nice job of thinking through the kinds of questions that we might use to frame this discussion. And I mean, he focused on this idea of professional obligation, like, does conscientious objection conflict with professional obligation? And I will deal with that question and with others in a way that are kind of related and were nicely highlighted as well in Jason's presentation yesterday. So just to start with, I'm going to frame this debate, talk a little bit about the scope of conscientious objection in healthcare. My focus in a way is to respond to commentators who argue for, for a ban, this should read, or heavy restrictions on conscientious objection. And the three reasons why I think we should permit conscientious objection, if you will, that provide a good basis for permitting conscientious objection are, namely, forcing someone to do what they believe is gravely wrong, causes moral and psychological harm. Secondly, that medicine is contested. And thirdly, that there's limited evidence of a deleterious impact of conscientious objection on patients and service provision. So I'm going to go through those claims and defend them in this presentation. I defend certainly the first and the second claim at length in my book, Why Conscience Matters. So you're most welcome to consult that if you'd like to see a more developed defense of these positions. But I wanted to start, first of all, by talking a little bit about conscience in the Catholic moral theological tradition, because I do think that this being a conference on Christian bioethics, that we should in a way situate this this topic within some sort of theological framework. I'm Roman Catholic, so I'm going to, and I work in the Catholic tradition, at least in some of my work. So I'm going to develop a Catholic account of conscience here, but obviously within the Christian tradition or the Christian religion, there are many different approaches to conscience, not necessarily mutually incompatible, but if you will, with different emphases. So conscience is, as I think was highlighted really nicely by Jason yesterday, according to Aquinas, is just the operation of practical reason viewed under a particular aspect. So I think there can be this question in the conscientious objection literature about, like, what is conscience? Is it just deeply held values? Is it like feelings? And I think on the Thomistic conception, fundamentally, it's the operation of practical reason. So it does have effective dimensions to it, and Aquinas, I think, deals at times with the emotional and spiritual dimensions of conscience, but certainly in the Summa Theologia, he focuses most directly on conscience understood as the application of general moral principles to specific cases, and that's the definition, if you will, of conscience that he provides. And then there's also this discussion of the problem of an erring conscience. Like, does conscience always bind? Are we obligated to follow a conscience that is in error? And I think sometimes people can get a bit tripped up on this question, thinking about, oh, well, like, what should one do when one's conscience is in error? But I think it's important to realize, like, we don't actually realize when our conscience is in error. Like, insofar as it is the operation of practical reason, and it is just our best efforts to get at the moral truth, if you will, all we have to work with is conscience in a certain way. Like, it is the horizon of our moral insight. So I think that's important to bear in mind with this question. And in the end, even as Philip Foot says, even an erring conscience binds because the will tends to an action as something evil in that reason has proposed it as evil. So we have an obligation to follow conscience insofar as we have an obligation to act reasonably, to act with understanding, and in a consistent manner, a manner consistent with the functioning of practical reason. So in a way, like the functioning of conscience is one way in which we pursue the good of practical reason. So there's actually a good that we realize by following conscience. And I think that's important to bear in mind here as well when we're thinking about the costs of violating conscience, of transgressing conscience, that there is actually an important good here, namely practical reason, that is at stake. And that can sound a bit abstract, but I mean, in the end, what else matters more, that we are kind of true to what we think is good and true and right in life. So I think that's important to bear in mind here. And I've got a note briefly there about Veritatis Splendor, that we have a duty to form conscience, of course, and the conscience is formed in community and elevated by grace and so on. So there's a lot that could be said here, but I just wanted to put this theological backdrop into the discussion, because I do think it's important that we do keep this in view. For those of us who are working in different Christian traditions, this discussion is very much nestled in a rich historical exploration of the functioning of conscience. So just by way of definition, I think we can also distinguish what we might call individual versus institutional conscientious objection. So often in like social debates, the term conscientious objection can be applied in various ways. So it can be applied to individual doctors who don't want to participate in procedures to which they have a moral objection. It could be also applied to institutions which have a mission-based objection, if you will, or a kind of values-based objection to the provision of procedures within the institution. So, for example, a Catholic hospital that won't provide terminations of pregnancy or medical assistance in dying or what have you, that might be an example of institutional conscientious objection as I am defining it here. So just to this topic of framing the debate, it's good to ask, what are we talking about here? And I think to some extent this work has already been done by Alberto, but I would note that the conscientious objection debate is often conflated with debates about abortion and euthanasia. But I would argue that conscientious objection in healthcare actually has a much wider scope than just socially contentious medical procedures. And in fact, that insofar as medicine aims at the good of health, one could argue that all medical procedures have a moral dimension. They all aim at realizing the medical good. So this goes back to Alberto's point about this question about whether medicine is in fact a moral enterprise. And I would note that I know that this is a controversial position, that there are people who might take issue with the claim that medicine is a moral enterprise, and they might take a more descriptive approach, or they might argue it's more based on a kind of conventional assertion of a set of moral values on which the profession is based. But I would note as well that there are in fact many different philosophical views in the philosophy of medicine that seem to converge on this insight, that medicine, at least if it doesn't even if it doesn't aim at the good of health, is a moral enterprise. And to some extent, like, that's all that's really necessary to get to this conclusion, that in fact conscientious objection needn't be confined to some small set of socially contentious medical procedures, but in fact cuts across medicine as such. And in fact, you're butting up against ethical considerations all the time within the practice of medicine. So to some extent, we ought to take into account the full scope of medical practice when we're thinking about this topic. I use the example there of a nurse who could object to the administration of weekly blood transfusions to dying patients with a poor functional baseline. Like that, in my view, is relevant to this debate, just as is a doctor who doesn't want to perform abortions or participate in the provision of euthanasia. I defend this perspective in the paper cited there. So I want to argue that we shouldn't ban or heavily restrict conscientious objection in medicine. Heavy restrictions, in my view, mean limiting conscientious objection to only a very small subset of procedures and placing strenuous conditions on the right to conscientiously object. So I have a problem as well with regulations that limit, for example, doctors' right to conscientious objection such that they have to refer patients on to other medical practitioners by virtue of what I would call an effective referral, which is a kind of technical term coming out of a legal debate in Canada about essentially like written letters that doctors need to issue to refer patients to euthanasia if in fact they're unwilling to provide or assess a patient for eligibility for that service. So I don't have a problem with like there are certain kinds of, if you will, more like remote referrals or less proximate, less direct referrals that maybe we can debate the ethics of. But I think effective referrals, I would raise questions about. So why am I taking issue with this attack on conscientious objection? Well, I think there's three reasons. And the first one is namely that forcing a clinician to do what they believe is wrong causes moral and psychological harm. So you could argue like that this is just like one consideration amongst many, and you could wonder why I'm placing so much emphasis on this. Well, in my book, part of my project, if you will, was to respond to what I perceived to be a kind of crude utilitarian critique of conscientious objection, which was something along the lines of the medical system has to be reliable, doctors have to be relied on to deliver services that are safe and legal and in accord with good medical ethics. When doctors conscientiously object, that creates this uncertainty, limits on access, inconvenience for patients. And in the end, like, doctors' own obscure moral opinions don't really carry much weight, don't really have much moral significance, shouldn't really be some sort of a deal breaker in this discussion. And therefore we have good reason to place heavy restrictions on conscientious objection. So it's a kind of utilitarian argument, like there's a huge cost to allowing doctors to conscientiously object, and there's not much cost to restricting conscientious objection. So I completely reject that view. I completely reject that view. I think there is a huge cost. to requiring doctors to violate their deeply held moral beliefs, or to place it in a kind of probably a more appropriate Thomistic framework, like to require doctors to act against their best judgment, act against the dictates of practical reason. So sorry, just my headphone here. I think my audio is still going good. There are different ways in which we can say that an action is wrong. I'm going to talk a little bit about appeals to conscience here and like what I think they're getting at. So like, if you will, what aspect of practical reason are we looking at here? So we can say that an action is wrong because of its intrinsic character, because of its consequences, or because of the intention of the agent. And I would argue that an appeal to conscience is a particular way of describing the wrongness of an action. It's not just in a statement about the intrinsic character of a moral act, but it also highlights the personal implications of commission of the action by an agent. So part of my inspiration for this argument was in fact found in Bernard Williams' Moral Luck, where he, a book published in the early 80s, which has an essay in it called Conscience, Character, and Morality, where I think Williams critiques both Kantian and utilitarian accounts of the morality of human actions for their lack of recognition and acknowledgement of and exploration of human character, human moral character. So appeals to conscience, in my view, are statements about the consequences for personal integrity and more specifically moral character if an agent engages in an action that they deem to be wrong. In addition to passing judgment on the objective rightness or wrongness of an act, moral reason presents a picture of the moral action as it relates to the self, and it highlights for an agent the consequences that wrong action would have, not just for the world, but also for oneself. So this is from James Childress of Beecham and Childress fame in a 1979 article, Appeals to Conscience. When a person appeals to his conscience, he makes a hypothetical and prospective claim. He claims that if he were to commit the act in question, he would violate his conscience. This violation would result not only in such unpleasant feelings as guilt or shame, but also in a fundamental loss of integrity, wholeness, and harmony of the self. So the formation of and maintenance of moral character is a core feature of what it means to be a moral agent, and violations of character in the form of a contravention or abandonment of core moral commitments can have catastrophic moral and psychological consequences. So you could say, okay, well, look, what's the evidence for this? Like, is this just abstract moral theory? Well, this is where I think actually the moral distress literature comes into play. And Kate gave a fantastic presentation yesterday exploring how moral distress might potentially be relevant to the conscientious objection debate, and also some potential questions about like theoretical compatibility, whether in fact these are related concepts. So I think there is some conceptual work to do, but I don't think it's impossible to argue that in fact moral distress is a product of, in some cases, restrictions on the exercise of conscience in medicine and healthcare. So I think a good study which highlights this fact is Deborah Hanna's 2005 paper in Research Theory and Nursing Practice, where she interviews a series of nurses who were required to participate in elective abortions, despite certain objections, moral objections that they had to these procedures. And then there's quotes which I think highlight the moral cost of this. I think the initial distress was that I was doing the wrong thing, that ending a life was doing the wrong thing, and that was the most gut-wrenching thing for me. I just burst into tears. It just felt like someone socked me in the gut, and I just thought, oh, I can't believe this. So in other words, like, I can't believe I'm doing this, I think, in particular. So there is this idea that there's a kind of shattering of moral conscience when someone acts against their deeply held moral beliefs, their best judgments. So on to the second claim, like that medicine is contested. And I mean, this has already been highlighted to some extent by Alberto. There is a question about how we ought to characterize medical practice. What exactly are doctors doing? What is the role of medicine in society? There's a constellation of related questions here that I think are relevant to this debate. And we can ask, are doctors service providers? Are they public servants? Are they fiduciaries? are they something else? I would note, though, that critics of conscientious objection, they seem to have actually contrasting views about the nature of medical practice and the professional obligations of doctors. And I think this is quite important because, in fact, like there may be superficial overlap in terms of the practical conclusions that a lot of bioethicists are drawing about conscientious objection. But in fact, like their reasons for coming to these conclusions seem to differ like dramatically. And so to some extent, when people talk about like a consensus emerging in bioethics about conscientious objection, like it's a little bit misleading because it's sort of like, I think probably could also just be the result of maybe more like superficial reasons as to why people have an issue with conscientious objection specifically in practice, rather than necessarily some like theoretically thick or deep consensus that's emerged. One thing seems clear to me, moral and technical disagreement are ubiquitous in medicine. So for example, disagreements in neonatal ICU, allocation of ventilators, prescription of medical cannabis, involuntary admission of psychiatric patients. Like there's sort of a multitude of reasons why, or in which doctors, healthcare professionals generally may disagree about the advisability of a particular medical intervention and whether one ought to, in fact, participate in that. And actually, I think this is nicely underscored in Julian Sabulescu and Dominic Wilkinson's book Ethics, Conflict, and Medical Treatment for Children, from Disagreement to Dissensus, which I think kind of is strong grist to my mill in my argument, insofar as they do argue for a place for dissensus in ICU, in neonatal ICU, and other contexts. So I'm kind of wondering how commentators like Sabulescu and Wilkinson can square that with perhaps their writings elsewhere trying to argue for restrictions on conscientious objection. I would argue that certain epistemic virtues would appear to be relevant here, like specifically intellectual honesty and humility. So policymakers ought to acknowledge that those people with whom one fundamentally disagrees can in many cases have reasonable grounds for holding the beliefs that they hold. And that's kind of the argument that I develop in conscientious objection in healthcare, why the professional duty argument is unconvincing. In a way, I see conscientious objection as almost like another category to include in addition to those three sources of medical ethics that Alberto highlighted, like the law, professional ethical standards, and then like a kind of more abstract or moral and ethical, if you will, source of professional ethics, so kind of good medical ethics. Well, we can kind of have those three categories, but then we can maybe add another one, which might be conscience. And why do I mention that? Because I think it's important to realize like what the institution of conscientious objection is doing in society. There's a good question to ask in this discussion. Like, why do we have conscientious objection? It's got a kind of complex history, but I think certainly since the Vietnam War, it has come to represent a recognition that we can get it wrong. We can get it wrong with public policy, and certainly like governments and institutions can introduce policies that are hugely controversial, like massively controversial, and to give no quarter to those who might object to these policies, particularly where in a way they affect them directly, where it actually like requires something of the individual, is to ride roughshod, I think, over reasonable disagreement in liberal democratic societies. And I think that is important. I mean, I'm not like a kind of a liberal cheerleader, if you will, like trying to kind of defend some like thick conception of liberal democracy here. But I do think like that there's something to this idea of conscientious objection as an important check on the excesses of institutional assertions of power, assertions of a particular ethical view. And then lastly, I've kind of also just come to the end of my time, but I think there is genuinely limited evidence of a deleterious impact of conscientious objection on patients and service provision. And I think this is relevant more just from a practical policy point of view. So there is some literature that I think might be cause for reflection. So, for example, Louisa Keogh's 2019 paper on conscientious objection to abortion in Victoria, which consisted of 19 semi-structured interviews of abortion providers, I believe, in the state of Victoria, Australia. And there was some anecdotal evidence highlighted there of doctors not complying with the law, with adverse effects on access to care for some women. And there was an argument run in that article about like how, in a way, the conscientious objection clause in the Victorian Abortion Law Reform Act 2008 was being misapplied by doctors. Like that, in fact, the purpose of the conscientious objection clause was actually to try and restrict conscientious objection, but doctors were using it as a way to like protect themselves against the having to comply with this law. I think that's contentious, that claim, and also like, in fact, that as I think Keogh highlights in the study, like our results do not give any indication as to the size of the problem. Like, so in other words, we don't know how big of an issue this is. So just even if I were to take my like Christian bioethicist hat off here and put on my kind of like impartial observer hat, like it's not entirely clear to me that this is certainly not entirely clear that it's as much of an issue as people make it out to be. And then I think there is evidence, which is perhaps stronger in countries where there is just widespread social opposition to abortion, say. So Francesca Minerva has an interesting paper in the Journal of Medical Ethics on conscientious objection to abortion in Italy. But I mean, I'm not convinced that like the institution of conscientious objection is the real problem in that case. Like, I actually think that in fact it's the broader social opposition to abortion and a broader political landscape that seems to be the challenge in that case, and that in fact like crushing conscientious objection is not going to really solve that issue. So I think that's important to bear in mind here. That's all I'm going to say for now. I'm once again immensely grateful for Alberto for joining me in this discussion today. And I think we have about 20 minutes of questions. So thanks very much for listening to me. Okay, so we can probably just take questions if you raise your hands. I think, Abe, there's a question.
Thanks, guys. That was a lot of fun to listen to. And yeah, also really appreciate Alberto stepping up and doing this on such short notice. I actually have I guess a challenge for each of you to consider, because I think my view is sort of more in between both of you. So I'll pose one to Alberto first, and then immediately Xavier, and then you guys can respond however you want. Alberto, I didn't catch your critique of the reasonability view. And I was hoping if you could say a little bit more about why you reject that. One of the issues that I have with, not allowing for really any role of conscience in healthcare is that I am a public reason guy. That's what the reasonability view is grounded in. And I read this prohibition on conscious objection as issuing from a kind of, utilitarian approach to medicine, which I interpret as a kind of comprehensive doctrine sort of being imposed on how we practice medicine, and as a Rawlsian, I don't like that, right? I want to try to bracket out comprehensive. So I would want to bracket out your utilitarian approach just as much as I would want to bracket out like an Orthodox Christian conscience absolutist approach to this debate, right? And then for you, Xavier, I'm all about, what you're saying about the psychological distress of, clinicians being forced to violate their conscience. I'm all about, the contested nature of medicine within limits. But you yourself, you said you're a Roman Catholic. And my question for you is, why don't those commitments also translate into some protection for conscientious provision of secular clinicians who are working in, your Catholic hospital? So here in Michigan, 25% of our hospitals are Catholic. So we have many, many, secular clinicians who are there and want to provide referrals, want to provide prescriptions for purposes of birth control want to provide, puberty blockers or any number of these things, and feel very, distressed at the fact that, they're facing an institutional conscience claim, which, as we know, is much stronger than an individual conscience claim, because an institutional conscience claim enacts a hospital-wide prohibition on these things. So it seems to me like the value of secular, for lack of a better term, the conscience of our secular clinicians in the Catholic hospitals isn't taken as seriously as the value of our, Catholic clinicians, for example, in our secular hospitals.
Okay, so I was taking notes about. Should I go first? So thank you for the question, because it helps me clarify something that I often find myself clarifying. I wouldn't consider my argument to be utilitarian in nature. People often assume I'm a utilitarian, and I wouldn't consider myself a utilitarian. So my argument is not based on, for example, I very much agree with what Xavier said about the harm of conscientious objection. I agree that in the vast majority of cases, the conscientious objection doesn't cause great harm to society. But I mean, there are cases, of course. One might say, well, even the risk of harm, even if small, is enough to justify like ruling out conscientious objection. Maybe, I don't know, but that would not be my argument. My argument is based on professionalism and the idea of a duty as a professional. So if anything, is the opposite of a utilitarian argument. Now, your point about pluralism. I'm not sure that this idea of reasonable pluralism, which is in itself problematic, because some people criticize Robert Carr views about conscientious objection based on the idea of pluralism, because like Marsh in bioethics, for example, they say, well, what is reasonable? Is abortion reasonable? Why? Yeah, that's a debate we can have. But to me, the problem is that is a view that is supposed to regulate like society, well-ordered societies at the political level. I'm not sure that the notion of pluralism, reasonable pluralism, that I think is I mean, it might be will be centered in liberal society, can be easily automatically transferred into professional settings that are freely chosen. It's as if, for example, views about violence, war, would be brought into the military context in those settings where there is no conscription, where someone chooses to become a soldier, say, which is a profession in the strict sense, in the same sense as medicine is, and then you would expect that these views about maybe war in this case is not justified. You would expect the same pluralism to be applied within the specific context that is chosen. To me, the idea of reasonable pluralism exists to the extent that people are free to choose their profession. I'm not ruling it out, but I will need an extra argument for saying that, yes, because this idea of reasonable pluralism is valid in society at large, it should also apply within a medical profession. There might be a good argument for that, but I will need an argument. I don't think it can be straightforward in the sense. That was my point, and I'd be happy to discuss more about it because it's quite a important point. Yeah. I hope this addressed your questions.
Okay, so I can jump in there. Thanks very much. A great question, and I should note at the start that I don't have super developed views on conscientious provision. Like, I realize that this is something I need to pay attention to now, and I plan to in the coming months. I mean, the two thoughts I have. Well, the first is I did actually I did write a response to Alberto, Julian, and there are two other authors on that paper. Like they're very, very, what I thought was a very thoughtful, well argued exploration of the ethics of conscientious provision that was published earlier this year in the Journal of Medical Ethics. And I wrote a response to that, raising some questions about conscientious provision related to rule of law, and then also in a way like exploring this kind of point of consistency, like what are the implications for conscientious objection if we allow conscientious provision and vice versa. So I kind of looked at a little bit of that, but in a way, like it's appropriate that one puts pressure on my argument from the opposite perspective. And I mean, for me, I think like one consideration that makes me a little bit nervous about the notion of conscientious provision in, say, for example, like religiously affiliated healthcare institutions is this problem of undermining collective agency. Like in a way, like what are religiously affiliated healthcare institutions? I would argue on one conception that they are a group of people coming together to pursue a common goal, and then often that goal is kind of closely linked to a specific ethical positions, like specific values. And there's a question about like, are those values pursued by this collective being undermined by the conscientious rejection of a few conscientious provision by certain clinicians within that institution. So that would be a point I would want to resolve and like look at closely in the coming months. That's all I've got at the moment. So thanks for the question, and I need to do more work on this topic. I think Kate was next.
Thank you so much for this excellent presentation. Really great to see these different views. So I really appreciate the dialogue. So thank you for this opportunity to have these two really strong and diverse views. I have a question for Alberto and then Xavier. And this kind of goes off of something that, I'm sorry, there's my daughter, that Xavier said towards the end, you know, that professional groups can determine something wrongly. And I'm just worried that the view you're putting forward idealizes professional groups. Like the kind of debate that you were talking about that could happen. I'm not sure that in this world or in different contexts that in different cultural contexts that's always happening. Like if it did, then maybe I'd say, yeah, okay, that sounds reasonable. But given the situation that we are in, conscientious objection seems like the best route until those groups function in this kind of way that you described that they should. I'm not sure that they do. And then, so I'd love to hear more of your thoughts on that. And for Xavier, I'm very sympathetic to the view of the moral distress or at least psychological distress that could be incurred by healthcare professionals in light of conscientious objection or not following their conscience. However, in the moral distress literature, the emerging point more seems to be about the moral distress of the patients who were denied care, especially in light of Dobbs. So, you know, women going places where they couldn't get abortions that they were seeking, and the patient's moral distress is the concern, and that given professional obligations, that should be the concern over the healthcare professionals' moral distress. So I'm not sure if focusing on moral distress gets us anywhere. Maybe it does, maybe it doesn't. So I'd love to hear more of your thoughts. So thank you so much.
I mean, should I go first just because of audio? Okay. Thanks for the question. Yeah, I didn't mean to give the idea of being super optimistic about the way society can debate and deliberate about anything for that matter. My point was a bit less ambitious in a way. So it was really about whether conscience is necessarily, or is even in most cases, more reliable than something that at the very least has some publicity requirement, because whatever we think set the standards of professionalism, according to my view, according to this criterion, is at least public. So if you have a legislation that either permits or rules out abortion, that's, I mean, in our society, is the result of publicly available deliberation. Everyone has a say in those things. In fact, states in the US that ban abortion, they do it based on democratic procedure. So because democratically supported elected governments decide that abortion is not legal, and the same for those who keep abortion. And the same is true, or maybe it should be true. Maybe that's something that should be changed about the way professional organizations arrive at their conclusion about, say, their codes of practice. So I don't think that the way it's done now is necessarily the best way of doing it. So I don't like the idea of professionals getting together in a room, not professionals, just a small group of professionals, and deciding what goes into a code of ethics of a professional, maybe. But if anything, that should be changed. So I'm not optimistic about that. My mild optimism is about the publicity requirement that exists when it comes to creating the standard of a profession, at least in liberal democratic society, that to me, I don't see that in the case of relying just on individual conscience, because conscience is opaque in that respect. One might have very, very good reasons for their own conscientious view, but in a society, the important thing is that they need to be made public if they are going to affect the way a certain service is provided to society. I know that, so because people are often concerned about, so one example is often used, the Nazi example. Someone will say, well, of course, we had the example of the Nazi practices, and it was good that doctor would conscientiously object back then. So it'd be good if the doctor would conscientiously object, because then we avoid the risk of having those kind of practices. But one problem with Nazism and that kind of society is that was not a democracy. There was not much transparency. So we do have that level of transparency, publicity now, and that is worth preserving. If anything, we should push for more of that, including among professional organizations, because after all, they also responded, they're accountable to society. So that was my point. So I will emphasize the publicity requirement of setting professional standards. Thanks.
I might jump in here. So I think that's a great question as well, Kate, about the moral distress of patients. I would say that I would want to sort of separate the two issues. So I would argue that the moral distress of patients that I think you're describing, as you said, after Dobbs, that seems to be related more to a legal context in which these patients are seeking a particular medical service. Like, I think that, in fact, conscientious objection is not so much if you will, like, what's the potential impact on the patient? Well, it's that they may have to go to another medical practitioner, but not necessarily like they may have to go to another state or something, like to access an abortion, say. So, I mean, I have very strong views on abortion, obviously, but like, I think that I would want to separate these two issues, like, and say that in fact, that just taken in isolation, conscientious objection, I wouldn't say that there's as much of an impact in terms of moral distress for patients as, say, like this Dobbs situation. So just dealing with like individual practitioner conscientious objection. That would be a question, at least an empirical question, maybe to explore, like what specifically is the impact of conscientious objection? To some extent, like that's the question I raised at the end of the presentation. So, yeah, and in a way, like why did I want to bring moral distress into the discussion of conscientious objection? Well, it's partly because I feel like there's been an underrating of the cost for medical practitioners, while I think there has been attention paid to the cost for patients. So in a way, I was trying to kind of even it up a little bit. So that's all I'll say for now. I mean, I'm looking forward to discussing this further. I think Nick was the next.
Hey, well, first, thank you both for the great presentations. My question was for Alberto. Sorry, this may be a kind of ill thought out question, just because this is the first time I'm really thinking about the issue in this way. But I was curious about, in your view, the distinction between the private and professional life, and kind of where the boundaries are between those two lives. Because it seems to me that, I mean, on the one hand, one can take their professional life as just one aspect of their private life, depending on who you're talking to. But for instance, I'm thinking of, let's say in the UK, you have the General Medical Council, who states that it's a professional duty for a doctor in a case of an emergency when they're off duty to provide medical assistance. Now that seems to be a case of their professional duties are encroaching upon their private life. So I'm wondering when there's, like, I guess, yeah, first, what's the strong distinction? And when there's a conflict, is it always the professional life that wins out, or how do we balance those two?
Well, that's a good question. So the short answer is, I don't know how to balance, because, I mean, you're absolutely right that you cannot draw a line and ask any professional to live out their own personal sphere, private sphere, as this, from 9 a.m. to 5 p.m. and then put their personality or personal life back. the problem is that when there is a conflict, what to do with that? So yeah, I'm thinking about your example of doctors in a way having to be on duty even when they're not in case of emergencies. So you take that as an example of a case of the professional life taking over the private life. To me, yeah, I mean, it's a good example, but to me, that's an example that, I mean, I would use it to support my point. So the idea is that that's widely accepted, right? That your professional obligations, in some cases, are, I mean, have priority over your personal life. And in your example is the case of emergencies. I mean, that's widely agreed. I mean, it might be wrong. I don't know. That's widely agreed. So emergency is one case, but when I say, well, what about patients' rights? So if a patient has a right to receive a certain service, why isn't that a case for also making sure that your professional obligation take priority over your private life? So, I mean, to me, it's because we already, so yeah, you're right, we already do that. My argument supports the idea that we should do it also in the case of conscientious objection. Now, of course, there are other cases where you can't really separate your personal life and your professional life, because you're not a different person when you do your job. You're the same person. But my point was there is such a thing as a professional conscience, and your professional conscience is about following professional obligations. So, yeah, I mean, I don't know where to draw a line, but it seems to me I will use your point in support of my argument. But yeah, that will be my answer.
Okay, I think we're at 10:15 Eastern time. So I think it would probably be best that we draw the discussion to a close and take a short break until the next session, which starts at 10:30. So we're using the same Zoom link for this morning session. So if you just come back to this Zoom room at 10:30, I'll set up breakout rooms for the next sessions. But I'd just like to take this opportunity again to thank Alberto for participating in this debate, and it's been a very fruitful discussion. So I'm sure on behalf of everyone.
Thank you everyone for the question, participating. It's been very, very interesting to me. I will be here for the next session. So yeah, thank you very much.
Thanks again. So we're back again in 13 minutes.